Welcome everyone to the final session of our Yale Survivorship ECHO. We've reached the 6th go around of it, and thanks for having me back again. I've been away for a few weeks here, got married, and then I have COVID. So I apologize that I've been away. But so we are very excited for our last session to have a few guest expert panelists here with us today. We have Franklin Brown. He is associate professor and chief in the Division of Neuropsychology here at Yale. And then alongside with him, we've had Michelle Kirshner step up as part of our group here and want to also provide a little bit of a presentation with a colleague as well. She's a nurse practitioner and director of program development, survivorship, and supportive services at the University of Cincinnati Cancer Center. And she's bringing with her today also Rona Schatz, who is a DO. She is the division director for behavioral neurology. Bob and Sandy Hyman Endowed Chair in Research and Education in Alzheimer's Disease, also at the University of Cincinnati. So we welcome all of them to join us for today's session on cancer and cognition. I see Dr. Brown here, I see Dr. Schatz, I see Michelle. Thank you all for being here. And so again, just some quick announcements before we jump into their presentations. This is our last session. After today's session, there's going to be a post-clinic survey that goes out. That will entail the entire 6 sessions. So any feedback you have on what we can be doing better in the future, we'd be happy to hear from you on that. And then for everyone who's joined now, if you can please put your name in the chat just for a quick attendance so we know who's here. Can keep track of that. That would be very helpful. So I think I gave co-host to Dr. Brown. I gave co-host to Michelle. So Dr. Brown, I believe I will be turning it over to you to go ahead and share your screen and the slides and get us started.
Let me just get that slideshow started. Okay. Almost.
No problem. And while you're getting that ready, I'll just say we are welcoming questions during the presentation. I'll try to manage that as best I can, but you know, depending on the number of questions, we might hold off until the end, but we can do our best to keep up with them as they come in. So thanks everyone for that.
So is my screen up there?
Can see it very clearly. It's perfect.
Okay, good. Well, I'm going to tell you about a woman that I saw earlier this year that has a history of breast cancer. I'll go over her information for a moment. She's a 45-year-old white female. She's very bright. She's a PhD in biochemistry. Works at a pharmaceutical company. She had a prior history of migraines and had given birth to 2 children via C-section. She has a family history of breast cancer and hypertension. Very healthy. And then at 40 years old, she was diagnosed with breast cancer. Her left breast was fine. Her right breast had, and you can see the, I don't know if the print's too small, but she had a mass in her right breast. Imaging showed some macro, forgive me, I'm a neuropsychologist, not an oncologist, so I'll try to say this stuff. Macrolobulated margin, regional punctate calcification. There was evidence of invasive ductal carcinoma, poorly differentiated. The right axillary lymph node was positive for malignancy, and there were some cysts in her lung and a lesion in her liver. So a number of things going on there. So she had a bilateral skin-sparing mastectomy, radiation therapy for a month. This surgery was complicated by a pneumothorax and required some extra treatment. She had a adjuvant dose of anthracycline and Taxol for 3 months, and letrozole. She was enrolled in a clinical study and for 7 months received treatments related to those studies. And she currently receives Zoldex and letrozole. Now, I was trying to find a good case for this. I was trying to find a clean chemotherapy brain fog case, and I couldn't find any. Every patient that I had that I've been seeing for cognitive complaints has complications, and I guess that's how we probably all are. I don't think anyone's a simple case. But after she was diagnosed and during her treatment, her husband left her. They were divorced. She had 2 children. She was a primary caregiver. She had, so she was managing these kids, working full time. She was already somewhat on the anxious side, and this ramped that up. She was anxious. She's having sleep problems, still having these difficulties. She often dwells over concerns which distract her during the daytime. She gets distracted at night because of thinking, so she wakes up a lot at night. She also has migraines. She's not taking any medication at this point for the anxiety. She is taking medicine for the migraines. She was also diagnosed with hyperlipidemia, but she's pretty thin. I mean, she's in shape. She's a BMI of 18.9. So she's a healthy person. She exercises when she can. In terms of cognitive concerns, she has problems with word finding and verbal fluency. This affects her at meetings, especially when she has to talk on the fly. So that is, that's distressing to her because she gets embarrassed because she doesn't want to look like she's making mistakes. And she reported some mental fogginess that tends to occur as the day goes on. So she tends to have more word finding problems as the day goes on. Her brain feels foggy. The MRI showed non-specific periventricular white matter hyperintensities. She did have a scan prior to chemo which showed some, but there was a progression of those after chemo in 2021. So I just want to go over, so I did a neuropsych evaluation on her, and I want to talk a little bit about the testing and why we use these tests. I'm taking it that most of you are not neuropsychologists, so you may wonder why they give this test. So I figured just talk for a minute about this and what it all means. So we like to start with an estimate of the person's IQ or intelligence. And the reason for that is the other tests are related to intelligence levels. So let's say somebody is highly intelligent and they get a low average score on a test. Well, that means something because a low average score for a highly intelligent person would be unusual. Let's say that the person has low average intelligence and they get a low average score. That wouldn't mean anything because it's consistent with what you'd expect. So we do this a few subtests of an IQ test to get an idea of how someone should be doing on the other tests, okay? And we also give a reading test, the same thing, to see if it's consistent with their intelligence. So she was very bright. She had a very superior verbal intelligence index. Her visual spatial intelligence was high average, which was lower for her, but it's consistent with her history. She always had better verbal than visual spatial skills. So this is normal performance. Block design was a little bit low, but probably normal. In terms of her language tests, so we also gave language tests to these patients. So there's 3 tests I used with her. One's called the Boston naming test. It's simply naming some objects. Another one's what's called the COA, or the letter fluency test, where you say the letter F, A, and S, and they have to tell you all the words they can that begin with those letters. And the other one was just naming different animals they could think of. Now these are in Z-score format. So a Z-score of 0 is average. Above that is above average. Negative is below average. So her Boston naming test and animal naming were 0.6 Z-scores, which is kind of on the cusp of high average. And these scores are actually adjusted for her education, so they're high average for other PhDs. Then phonemic fluency was low average of negative 1.1. And that is a thing that I often see with chemotherapy patients. We'll talk about that in a moment of why that is, but that's often the lowest score. And that does correlate with her complaints of word finding. Her visual spatial basic skills were fine. She had a superior judgment of line orientation. This is a task where they perceive different line angles, and she was able to copy designs just fine. Her memory functions were also very strong. The California Verbal Learning Test is a list learning test. It's got 16 words they're supposed to memorize. It's very challenging. She had a Z-score of 2.3 in the learning trials, which is almost perfect. Her long delay and recognition scores were 1.5 Z-scores, and they were perfect scores. She made no errors. The brief visual memory test is a design memory test. We have to draw designs from memory. That was perfect as well. The Brown location test is a test I developed where they had to memorize dot locations. And she had a slight dip on the long delay, but then it went back up to 1.3 and perfect score on the recognition. So her memory was great. Now on executive functions, TRAILS A is just a rapid trail making test, which really tests visual sequencing and target finding. That was a little weak at low average. Whereas TRAILS B, and again, this is low average for other PhDs, okay? TRAILS B was average and expected for her abilities. She was very strong in what's called the SDMT. This is a coding test, and I give this because it's usually kind of sensitive to white matter changes, but for her, she kind of aced, she did very well on it. So that was not sensitive to this case with her. And then digit span, that's just where you read the numbers to her and she repeats them back. Now, she had a little bit of variability on the test called the TOVA. The TOVA is a very boring 20-minute test of attention. And so they hit a button when there's a square on the screen, and when the smallest square is on top, they hit the button. When there's on the bottom, they're not supposed to. She did within average range on this test. She had a little bit of impulsivity towards the end, but interestingly enough, you'll see a little bit of that with anxious people. So people with prone towards anxiety, there's a little bit of impulsivity that goes along with that, and we can get into that. But it basically deals with the brain, and when you're a highly anxious person, your brain does not inhibit thoughts like other people do. Other people's brain does, so that can cause some anxiety. So nothing, nothing major. So just to recap, the only weaknesses were in the letter-based fluency. Block design was average, a little bit low for her. And then TRAILS A was a little bit low, and a little bit of variability in attention, but that's it. But what does this mean? Well, her complaints are verbal fluency problems, brain fog, mental fatigue, anxiety, and sleep problems. Well, it's good to conceptualize brain fog as what I call it is cognitive inefficiency. So basically, after chemotherapy, a certain number of patients' brains have to work harder to do things that they did before the chemotherapy. And the reason for this is that it affects the white matter to some degree. And so as a result, the white matter, as many of you probably know, is the connectivity of the brain. And so when white matter is damaged, the connectivity is not quite as efficient between different areas of the brain. And so that results in patients having to work harder to do things. And so the very subtle findings of the phonemic fluency being low, TRAILS A being low, block design being a little bit low, and TOVA being a little bit off, just tell us that there's not a drastic problem with her brain, but it's saying that the brain is not working quite as efficiently as it should. So in other words, it takes her more mental effort to think. And this is what we find with chemotherapy patients. So this explains why her fogginess gets worse during the day. It explains why sleep problems make it worse. And what I find is a lot of times, so if all she had was chemotherapy effects, she might not have that many complaints. But when you add the load to the brain, things become more obvious. So we start with just thinking. Thinking takes more effort. But now let's add to that. If someone's anxious, well, when they're anxious, their brain is doing two things at once. They're ruminating about what they're anxious about, plus they're trying to think. Okay, so that magnifies the effect and causes more mental fatigue. If they didn't sleep well that night, which she does not sleep well, that further adds to mental fatigue. So this is a common thing I see with these patients, and I try to explain it to them like this, is that the brain is just working harder. That's why you feel foggy. That's why it's not always a problem, but gets worse as you get tired. So what does the research say about some of these things? So I just have a few articles that are interesting. There was a meta-analysis of cognition and breast cancer. It's a little bit older, but it has, you looked at multiple studies, which I find helpful. And the strongest finding was that test I mentioned, that where you have them tell me the letters, that's the strongest effect of chemotherapy. And the reason for that is that phonemic fluency is really a measure of connectivity. It requires frontal subcortical connections. And so that's often the lowest test. Sometimes the CVLT is a little bit low. In her case, it wasn't, but she's very bright. Spatial abilities are a little bit low with block design. So while block design wasn't a problem for her, it was average versus superior intelligence. So it was a little bit low, I think, for her. So we have two scores that are typically low. And those are usually the most significant differences. Sometimes, and less consistently, they might have a little bit lower delayed memory scores. Their working memory might be a little bit low, and their dexterity speed might be a little bit low. And most of these are related to thinking efficiency. Now, simple attention, Trails A, even though it was low for her, it's not often low, but it was low for her. So let's talk about the mechanism for this. I mentioned white matter briefly. Now, not all patients are going to show abnormal white matter on an MRI after chemo. Some do, not all will. In terms of the white matter changes in research studies, they use what's called diffusion tensor imaging. And what diffusion tensor imaging does is it looks at the tracks of white matter and sees how good their integrity is. In other words, if a white matter track is well formed, it has high FA or functional entropy, which is actually just saying that's intact. And what they found was after chemotherapy, patients' white matter tracks were not as well defined. So there's some slight subtle damage in the white matter tracks. And on those studies, they found some weaknesses. Now in this study, they found a test similar to the TOVA was low, which we found a little bit of abnormalities. Trail making test A was low. The coding test was low, and pegboard speed. They did not look at verbal fluency in this study. But anyways, the point is that white matter changes were visible, which is consistent with what we find in testing and kind of goes with the test pattern. Now, the good news is, after 3 or 4 years of post-chemo, most of the patients' white matter tracks were similar to controls once again. So there is improvement in white matter. And I do a lot with white matter disease patients, MS, chemotherapy, and other patients like that are related to the immune system. I do find that immune system changes do often affect the white matter more than the gray matter. And the most obvious of this is multiple sclerosis in patients like that. But white matter, especially the younger the person is, can improve with health. So it's not far-fetched to see that the white matter does kind of get better after 3 or 4 years. But you might wonder, well, if that's the case, does brain fog continue? Well, for some people it does. Sometimes it's because the white matter hasn't gone back to normal, and sometimes it's because their initial problems caused a spike in their anxiety, and now they're worried about their cognition. So sometimes when people are worried about their cognition, it perpetuates the problems onward. Not all. Some people, there's still problems, in the white matter, but there is a certain amount of people that once they have problems, it's hard to get over that. And what happens is a patient will often ruminate, oh my gosh, I'm having troubles with this. And they start becoming hyper-focused on their problems. And that can kind of perpetuate that problem. It can go both ways. So what do I recommend for someone like her or for other patients? Well, we want to look at modifiable factors, things that we can improve. So there's evidence that anxiety adds to memory problems. We found that in a study, and there's other studies that have found that as well. And so And there's been research that finds that SSRIs, in this particular study, Paxil, does improve memory functions in anxious patients. And actually, this study used neuroimaging. They actually found that hippocampal volume actually increased after 6 months of an SSRI. So there's some evidence that SSRIs are helpful for memory function. So for this patient, I recommended that she talk to her doctor about getting an SSRI. And anxiety is also related to cognitive complaints. I recommended that she see someone for cognitive behavioral therapy. She is a very bright person, and I find this because I work at Yale, that we do have a number of anxious people that are my coworkers. Many of us are a little bit on the anxious side. It's what makes you successful in many ways, because you get a little obsessive, you want to do your best, so I talked to her about that. She's like this too. And I said, maybe some cognitive behavioral therapy to kind of help you be a little bit more reasonable with yourself would be useful. And she agreed. So that was a recommendation she followed through with. Sleep hygiene instructions. So my dissertation was actually on developing a sleep hygiene program. So that's kind of something that I like to focus on with my patients. But I go over things, I give them instructions on their report, but I also talk to them about different suggestions and things like that. And many times sleep hygiene instructions are counterintuitive to most patients, such as if you can't sleep, spend less time in bed, when their instinct is to spend more time in bed. So that's helpful. We discussed some compensatory strategies. She used to exercise a lot. She's not doing as much because she's so busy with the kids, but I recommended that if she did have time to increase her cardiovascular exercise, that's associated with improvement in function. And cognitive rehabilitation, we do have speech therapists that we can refer to. We don't have a cohesive program with this yet. And we're working at Yale trying to develop a more cohesive survivorship program for cognitive rehab, what I do and interfacing with them. But it's really kind of limited to what they can do for these kind of subtle problems, to be honest. Yeah, they can do some different exercises. They can do some computer-based activities that may or may not help. But the reality is her problems are very subtle. And so there's not a lot you can do for that. Anyway, so that's kind of my main points. But I'll be happy to talk about this if you have questions, or if you just want to go over what any thoughts you have.
Dr. Brown, that was a wonderful presentation. Thank you so much for sharing all of your expertise and knowledge with us for that. I think we got a lot from it. We already had a question during the presentation. Can this occur with other medications, such as chronic use of insomnia meds, pain meds, and seizure meds? Do you use any brain training with cancer patients? And if so, do you see any benefits? So sort of a two-part.
Yeah, sure. Well, to answer your question, medications can definitely add to thinking inefficiency and some reduced cognition a little bit. Chronic use of insomnia meds, they can affect your focus. Benzodiazepines, which are anti-anxiety medicines, are known to affect cognition in patients. Especially, you don't want to really give that to sleep patients in actuality. And in actuality, sleep hygiene has been shown to work better than medicines to help sleep quality. But so it's not really the best thing to use insomnia-based medicines. In reality, some people, they can't feel they can sleep without it, so I understand that. But ideally, it's good to avoid that because those medicines do affect your thinking efficiency. They do affect your brain, your actual sleep stages. Benzos and alcohol can inhibit REM sleep, and there's some evidence that REM sleep is important for memory and other cognitive functions, so that could be a problem. Pain, these are great questions. So pain can be very distractible. I'm sure we can all relate to some time where we hurt a muscle or felt some pain. But for patients with more severe pain, that can definitely be distractible. And someone asked about brain training. Like I said, it's hard to know if it's going to make much difference. The research doesn't find any good effect size for that, because brain training affects subtle things. in terms of computer-based programs, the jury's still out. Most of the findings don't really find that they sustain much with those, like luminosity. But can it hurt? No. Someone likes doing those things, why not? But it may not be worth the benefit of spending time doing that unless you like it, it can't hurt.
Great, thanks for fielding that. And does anyone else, before we turn it over to Michelle and Dr. Schatz, have any other questions you have for Dr. Brown or the group? Maybe there's a case someone has had themselves they were thinking of. Okay.
Well, I was late coming on to the ECHO, so I just want to say hello. And, Dr. Brown, thank you for coming and doing this presentation today. And I've sent you so many patients over the years who really just find it helpful to have even the assessment and the knowledge that, you're, like in this person's case, you're above average on almost everything. And I think some of that understanding what's happening and how it does or does not correlate to evaluation might help them just feel better and know that they optimize their sleep and their physical functioning and health, and maybe things will get better slowly. I'm not a survivor myself, so I don't know, but I just know my own patients have seemed to really appreciate the comprehensive nature of the Cancer and Cognition Clinic. So thank you for that.
Thanks. Yeah.
I actually had a quick question too. So if we're, counseling patients on cognitive changes after chemotherapy, and you can see these white matter changes for up to 3 to 4 years after, should that be changing the dialogue we're having with them about how long these effects can be had? Now, granted, you mentioned anxiety being a factor here too. How should we best be communicating that with our patients?
Well, I think if you take the time, I think it's great to talk to them about how it's there can be white matter changes for up to 4 years. You can tell that to them. You can explain to them that the fog is because the brain has to work hard to do the same things, but that it can get better over time. And also talk about, does this make you anxious? And talk about, you can, if you're feeling anxious about this, you can try this because it does sometimes help. And just talk to them. So normalizing it, say, and saying that, hey, you might not notice this every day. It's not just, you're not just inventing it. It's just, you're going to notice it more when you're tired. You can notice it at these certain times. And that can also, hearing them out and normalizing it and telling them it's usually not a severe thing, but it can feel that way, is helpful because it can be scary. These are many times, but sometimes you have really bright people who notice these subtleties, and it really affects them in this. And let's face it, when you're a professional and your brain's not working the way it used to, it can be very disheartening because you rely on that so much. So definitely having a conversation with your patients about this in general is always a great thing to do, and it helps them feel better, I'm sure.
That's some great advice. Thanks for that. In the interest of time, I do want to get over to Michelle and Dr. Schatz, who also had a presentation for us today too, and I'll turn it over to both of you. Go ahead.
Well, thank you so much for the opportunity to share with you.
Hold on one moment there. I think we're getting a lot of feedback. I don't know. Is there another computer logged on there or for this session? It could be feedback from that.
How now?
It still sounds like we're getting a lot of feedback.
Oh, it's still a lot of feedback.
Well, now that sounds a little bit better.
Okay, now it's better?
Yeah, there's still a little bit, but it's not like it was.
I think it's just
Maybe.
I think it's our
These microphones these days, it feels like they're going out all the time.
How about now?
Oh,
Yeah,
that sounds a lot
good.
better.
Okay, I have a feeling it was phone. All right.
Thank you.
Okay, so thank you all for the opportunity to share. And basically, what I want to do is kind of give some concepts that we use to put these symptoms in a bigger narrative of what's happening in the brain, not just with cancer, but the idea that people with cancer come to it with a whole host of all the rest of the things that have happened in their lives. And this is important to take into account. So I am going to...
Dr. Schatz, I'm just going to interrupt again. It's happening again for some reason. I'm wondering if maybe turning off the video just for a brief moment will improve the quality of the audio.
Okay, how about that?
No, it might just be the microphone.
How about now? Any better?
That is better. Yes.
Okay. All right. I think I just have to be up close.
Okay.
All right. I'm going to share my screen now. Okay.
Go for it. Thank you. Sorry about that trouble.
No. It says it's disabled participant screen share.
I didn't make you a co-host yet. Now I just did. I had made Michelle a co-host before. Forgive me.
Okay. Ready?
Should be ready.
Okay. Okay. And I'm beginning. Okay. All right. So one of the basic concepts that we have is that cognition is based on the functioning of networks. And we basically look at the brain as a complicated tinker toy construction where the round blocks are nerve cells, those blue tubes are axons, and cognition is basically over lifetime a buildup of these little orange pieces called dendrites. They mean little trees. And that this is really the place where both the building of cognition and its destruction occur at this dendritic level. And more importantly, these individual connections join up into larger groups called networks. And these networks have overarching functions. They're all interconnected towards a larger goal. And we can actually see these networks using technology. And this was alluded to Dr. Franklin in terms of the MRI. And it's important to kind of know that these different technologies are looking at different parts of these network connections. So for the structural connectivity or wiring between nerve cells and components of a network, we have the blue tubes, which are white matter tracks. And we can see this macroscopically on the MRI with the white matter, but also something called diffusion tensor imaging. In terms of knowing whether the centers themselves are functioning well, we have assessments of sort of the neuronal grouping. This is called functional connectivity. And the ways in which we assess this are through functional MRI, EEG, MEG, and PET scans. And this tells us kind of correlation between different centers within different parts of the brain. And it can tell us how, it can tell us the integrity of the different components of the network. And what really happens to affect cognition is changes in either the structural connectivity or the functional connectivity, the ways in which the nodes of the network are able to communicate the way they're supposed to with one another. And here's an example of diffusion tensor imaging, and here's a functional MRI scan. Now, based on functional MRI scan, we can identify cardinal networks in the brain. There's actually 5 of them, but 3 kind of are used most often because of the fact that they have specific associations with neurodegenerative disease. And we have what's called the default network or know what network. It involves the processing of our senses, making sense of it, and because of all the real experiences that we accumulate during life, we actually have our identity based on that, and it gives us a sense of self. And this is uniquely vulnerable in Alzheimer's disease and a couple of other pathologies. And then we have a network that's on the motor end. It helps us do things. This is what Dr. Franklin was talking about in terms of what was affected in this patient. And there's a type of memory, a working memory, or called short-term memory, or a mental workspace where we gather all the needed resources to accomplish tasks and have us monitor as we do tasks. And it involves visual spatial functions as well, because we do things in real space. So we have to have coordinates to do that. And this is affected by a neurodegenerative condition, Parkinson's Lewy body, but very, very vulnerable to all non-neurodegenerative types of conditions, and cancer being one of them. Sleep, medication, medical diseases, all those are going to be affecting this network. And then there's a network that has to do with knowing when to do things. It's what's supposed to keep us from actually saying what we think or doing something impulsively. Kind of a network that also stores cultural and social norms, so we do the right thing at the right time. And we know it helps us understand what's going on with others, which also should guide our behaviors, and this is involved in the frontotemporal dementias. Now, this idea of networks is important because it tells us kind of what happens to affect thinking over time. It's stuff that happens to networks. So there are destructive factors, and the ones that have been mentioned so far are those perhaps vascular disease, the sleep disturbances, cancer, but aging alone can affect the structure of this network, which is why age is a factor in cancer-related cognitive impairment, because we don't have good maintenance. And then there are factors that help kind of push, make the network more functional, has a lot to do with early learning, but things that are lifestyle issues that we want to promote in survivorship actually work in building the connectivity and providing what is known as cognitive reserve, an excess of connectivity, so that if we lose some from these other destructive factors, we have the ability to maintain function because of this excess connectivity. Now, I wanted to talk about the small vessel disease for a moment and some concepts behind that. We know that small vessel disease affects affects network functions, and partly it's because it breaks down some barriers to immune system activities that are occurring outside the brain. The brain is sort of immune privileged, and when it is exposed to some of the immune proteins that are in the rest of the body, those proteins don't always know that normal nerve cells and connections are normal and start to break them down, and so you see inflammation. And the other thing is small vessel disease affects the perfusion of some structures that are key to the networks. This leads to both silent and symptomatic white matter changes. And then if you have on top of it age and high blood pressure, you add to that problem. And we know that there's a certain threshold of small vessel disease that will lead to cognitive impairment. And we'll talk about that in a minute. One thing that's also important to take into account is there's some heritability of small vessel disease that might be independent of all the other factors like hypertension, for example, or diabetes. And that means that there are probably other reasons for the small vessel changes besides the usual culprit. This is just sort of,
Dr. Schatz,
Yes.
forgive me, I don't mean to interrupt. It's happening again with the microphone. It's starting to maybe moving a little closer can help. I'm not sure.
Yeah, I wonder the cycle. Okay.
Yeah. Okay.
That's
This
much
is
better.
just, okay, this is just kind of a look at the different white matter changes. They all have importance in terms of what they mean. And I won't go into details of that, but just to know that the detail of what the white matter changes are what you want to know from the neuroradiologist, and that not all white matter disease is vascular in nature. So the ones we just saw with a certain distribution, mostly deep in the brain near the basal ganglia, and more diffusely throughout the brain, are more likely to be vascular. But the ones that are white matter changes that tend to be dominant in the back of the brain and may be associated with hemorrhages and non-lacunar strokes, these can be due to neurodegenerative disease and Alzheimer's in particular. So this is important to know about when looking at MRIs. Another thing is that when we look at cognitive impairment, it's often, vascular disease is often given as the reason for cognitive change. And what we now know is that vascular disease is very rarely a cause of progressive cognitive impairment. Alzheimer's pathology is the main determinant, and that's represented here at these top three lines on the graph. Lewy body Parkinson's causes a more intermediate progressive change in cognition, and vascular disease is very close to some of the cognitive changes that occur with aging. So it's really important not to always use that as a default. And if something is progressive, particularly in people over age 50, you're going to want to look at other pathologies. And what we now know about what correlates with vascular disease or these white matter changes in cognition is how it affects the networks. And what we now know is if we were to make measures of network efficiency through fMRI, for example, or even PET scan, when we start to see a decrease in network efficiency and strength, that's when cognitive impairment occurs. So you can have a lot of white matter changes, but if that network still is able to function by its distributed activity, you're not going to have cognitive change. And one of the most sensitive areas to be associated with cognitive change is a group of white matter connections called the inferior longitudinal fasciculus. And this happens to be the white matter tract that serves the default network that is associated with memory functioning. And it's when this network is involved that we begin to see true cognitive change from white matter disease. Now, another comment, another finding in this case was an anxiety disorder. And I think we think of emotions as reactive, but it's important to know that they also might reflect underlying brain pathology. And it's a concept that we call mild behavioral impairment, which means that not just cognition, but moods can be the presenting set of symptoms for brain pathology or a disrupted brain. And we also know that particularly over age 50, if you have a set of either mood or behavior changes on a questionnaire we use called the neuropsychiatric inventory, that you have a higher risk of having underlying neuropathology. And the number of symptoms correlates with that increase in risk. So again, neuropsychiatric symptoms may actually be reflecting underlying neuropathology. One of the concept about treating mood disorders is that it can improve memory. And we think that one of the mechanisms is that it actually helps to reduce some of the pathologic proteins that begin to lead to neurodegenerative disease, namely beta amyloid. And there's evidence that an SSRI, escitalopram or Lexapro, works in individuals by helping to reduce amyloid. And in rats, part of the mechanism is it upregulates a amyloid enzyme that promotes formation of more normal length amyloid than the abnormal length amyloid called that leads to beta amyloid. Another concept is that moods, certain aspects of mood changes actually reflect inflammation and have a direct association with it. When we look at depression, for example, there are mood components, there are cognitive components, and there are physical symptoms. Mood components have no correlation with other underlying inflammatory markers, but one particular cognitive symptom, apathy or lack of initiative, is associated with the inflammation markers, CRP and IL-6, and somatic symptoms affecting appetite, energy, the sense of effort, and sleep also correlate with the presence of inflammation. So it's to say there are components of the mood disorder that actually are symptoms of the inflammation, and that some of this is not just reactive, particularly the sleep issues, and not to say that sleep hygiene isn't important, because it absolutely is, but that we have to take into account it's physiological as well. The other thing we know is people who have predisposition for depression also seem to have genetic risk for abnormal inflammatory responses, and that this combination of depression and inflammation may be genetically determined. This slide has a lot of information that I'm not going to go through now. It'll be there for your as a resource. But it's important to know that we need to be paying attention to these mood disorders, even if they present with cancer, because the sustained mental health symptoms will increase the risk for dementia later on. So we can treat mental health, we can prevent dementia, and if we treat mental health with the general brain health types of interventions that we use, we can help prevent dementia. Then I want to talk about sleep. And sleep issues kind of have multiple ways in which they affect cognition. It's important to know sleep goes through stages, and each stage has a particular function in processing a different type of memory. And that means
Dr.
that
I'm
yes.
so sorry to interrupt. I just want to let you know we just have about 10 minutes left in the session. Okay.
Sure. Yes. And I think I just have a couple of slides left.
Yep.
This is just to say each stage is important, and it's disrupted sleep that is really going to be a factor that is going to lead to other problems in terms of not just the cognition issues that a person is having now, but a future risk for Alzheimer's disease in particular. There's a stage of sleep called deep sleep, in which these little glial lymphatics dilate, and they allow spinal fluid to come in, kind of like an ocean tide, and flush away toxins that build up. And in cancer, there is an increase of inflammatory reactions and inflammatory proteins. Also amyloid, because it is an inflammatory protein. And if we have sleep problems not addressed, and in particular identifying sleep apnea, which often is mistaken for insomnia, then we're missing out on an opportunity to improve cognition. So that is my commentary on the case, and I'll be happy to take any questions.
Thanks, Dr. Schatz. That was a lot of great information and really enlightening about, all the factors we should be considering among cognitive changes with cancer as well. We did have some changes, excuse me. We did have some questions in the chat that came up.
Yeah.
One of the questions was, so can cancer inflammation cause mood changes?
Mm-hmm.
Yes.
And maybe if you want to talk a little bit more about that.
Sure, it's a two-way street. And I think it's important to remember that emotions serve a function, okay? They're like the early warning system saying to us, hey, pay attention, something is going on, something's not right. So the studies are showing that inflammation is driving the mood disorders in some instances, and particularly the symptoms that I mentioned in that one study, the apathy and the somatic symptoms, including sleep, are probably driven by the underlying inflammation.
Yeah, so what do you recommend? Yeah, and one of the things, kind of when we talk about all this information is how does that play out into our clinic? So, again, this idea of being global and treating the patient. So looking at, this is exactly what you talk about, nutrition. How can we improve and reduce inflammation through optimizing nutrition? So we recommend certain diets for patients, exercise, using mindfulness, meditation, de-stressing, all of these lifestyle behaviors. So, but it's not a one-time, this is an ongoing type of intervention, which is then looped in with, sleep assessment, looking at, getting a sleep study so we can look at actual stages of sleep in addition to looking at disruptive sleep and sleep patterns that need cognitive behavioral therapy. And for time, I want a lot of time for discussion. I just want to mention one other thing, which is kind of what I think Dr. Schatz was getting at, is that a majority of our patients we see in the clinic they're not the 40-year-old who just presented. That is our wonder patient. Most of our patients are older patients who have been treated for cancer, and so we're basically dealing with the fact that there's many, this might not just be purely cancer related. There might be underlying neurodegenerative, and that's kind of the thing that I wanted to specify is it's complicated. It's complicated, and it needs somebody who's going to be helping these patients over time. So that's where, the program we developed is longitudinal. We see patients to help them through their cognitive issues.
It sounds like such a robust program you guys have there, and I wish we all had access to that. But with that in mind, another great question came up in the chat. For those who have an absence of a cancer cognition clinic, for patients experiencing prolonged cognitive changes affecting function, what would you recommend, and would that include referral to neurology?
Yeah, so I'm going to just say how our program started, because I was like everybody else. I did not have this program. I was just a survivorship provider. And what I needed to do was I needed to find someone to refer my patients to. And so I just found Dr. Schatz. She's the head of memory. She did dementia. And I said, Dr. Schatz, do you think you could see cancer patients? And she's like, I think I could learn that. And within a few years, she's an expert in the area. So my recommendation is absolutely, if you don't have it, find somebody to partner with and have them there and see if they can develop that specialty. I don't know if Dr. Schatz, maybe she's sad I found her, but.
Basically summed up everything about survivorship, multidisciplinary care, and how we grow from the inside, and organically. So thank you for that. It's a very fitting way to end this ECHO series, actually. Right, Jevin? We have 3 minutes left. I'm not sure what.
Yeah, I totally agree. Couldn't have summed it up better, and what a good way to stamp it off with that multidisciplinary approach in finding champions like all of you in other disciplines that can help support our survivors. And so, my goodness, I feel like if we allowed for it, we could be talking for days. We have been talking for at least 6 hours here over the last 6 sessions. So, you know, I hope this doesn't stop here. We've talked about as a group doing an ECHO 2.0, bringing everyone back, doing a deeper dive into topics. I think that would be a lot of fun. So stay tuned for that. We will be in touch, and know that this community doesn't just end after this session. This continues. If you have questions, if you want to connect with someone, reach out. I'm happy to be a point person and direct in that way too. We want to foster that through this too. So with that said, I'll send out the last email for our sessions at least, and include that post-clinic survey. You can get that back to us, but it's been an awesome ride with everyone here. You've been so engaged, and it's really made it the best ECHO we've had by far. So
For sure.
thank you.
Yeah. Thank you, everyone.
Thank you very
Enjoy the
much.
rest of your
Thanks,
summer.
everyone. Enjoy the great weather. Bye.
Hey, Jevin, stay on.
Can you get the chat here, Jevin, so we can get a list of the people?